Good evening, madam.
Good
Today I
evening.
am presenting about a patient who is a 38-year-old male. 38-year-old male, Mr. Parivel, a right-handed male hailing from Tanjavur, educated till 12th standard, working as an electrician in Tamil Nadu Road Transport Corporation. He presented to us with complaints of weakness of both lower limbs for the last 28 years, numbness of both lower limbs for the last 26 years, weakness of both upper limbs for 33 years, and numbness of both upper limbs for 3 years. Patient was normal till 10 years of age, that is 28 years ago, when he developed weakness of both lower limbs. In lower limbs, initially he had difficulty in insinuating his feet into the slippers, and he would require to negotiate the slipper onto his foot with his hands. After walking for some distance, he even noticed slippage of his slippers, and he was initially aware of the slippage. 6 months later, he stopped being aware of the slippage, and he had to look down or be reminded by a friend to strap his feet back onto the slipper. Later on, it compelled him to change to sandals. He simultaneously noticed that his calves were thinning by the day. 8 years later, that is at 18 years of age, he also noticed tripping of toes while climbing stairs in his school and over the entrance to his house. He had to take support of a wall to prevent falls. In order to prevent this, he used to lift his feet high off and stamp it on the ground, and he would make a stomping noise while climbing stairs. 3 to 4 years later, he tripped while walking on level ground as well. Around 1 to 2 falls per month. Over the last 8 years, that is from 30 years of age, he has difficulty in climbing stairs and getting up from squatting position from Indian toilet. He managed to do this with support of rails or wall. Over the last 4 years, that is from 34 years of age, he has had difficulty in climbing downstairs, and he would often feel his knees give away and cause a buckling sensation. For the last 6 months, he has difficulty in getting up from squatting position. And he has to take support of his hand. Initially, he has to put it on the floor, then on his knees, and he has to climb upon himself. Now he requires one person's assistance in pushing him forward while boarding a bus. Over the last 26 years, patient also has complaints of swaying while washing his face and leans onto a wall to wash his face. He noticed swaying increases when he walks in the dark or when there is a power cut in his house. He says that he is able to feel the floor while walking and able to appreciate insect bite and hot and cold water sensation while taking a bath. There is no tingling or burning sensation. He has multiple foot ulcers over the last few years, most of which have healed. He makes a stomping sound while walking. Over the last 3 years, that is from 35 years of age, he has weakness of upper limbs as well. It was insidious onset, gradually progressed, initially in left upper limb, followed by right upper limb. He has difficulty in lifting heavy weights. Earlier, he was able to lift a motor which weighed around 20 kilos with one hand. Now he loses the grip and the motor slips away and falls unless he uses both his hands. He also developed difficulty in grabbing the railing while climbing bus, or he has difficulty in picking screws and buttoning and unbuttoning his shirt. He has difficulty in mixing his food and picking up coins from his wallet. Over the last 2 years, the same complaints developed in his right hand as well. He has difficulty in holding a pen and writing. His handwriting has changed over the last 2 years, and even difficulty in feeding himself. He has to use a spoon because he can't hold the rice grains in his hand. It is associated with deformity of both hands in the form of folded fingers, and he is not able to make a fist. But he's still able to bring food to his mouth. He's able to apply soap to his face, and he's able to raise his hand above shoulder to comb his hair. He says that he's able to feel objects while handling them and able to appreciate pain sensation on insect bite upon his hands. He is able to appreciate hot and cold sensation of water on his hands. There's no tingling, burning sensation. There's no history of thinning of forearms or arms. None of the weakness symptoms show fatigability or fluctuation, no diurnal variation of these symptoms, and it doesn't improve after a period of rest. There is no tightness of limbs, no difficulty in lifting his neck from the pillow or turning in bed. There's no history suggestive of a truncal weakness, no shortness of breath, no history of neck pain or shock like sensation on bending his neck, no history of bowel or bladder disturbance, no skin changes such as shininess of skin or nail changes. However, he does give history of ulceration on foot. No history of backache or band-like sensation. There is no history of fever, headache, seizure, altered cognition, excess forgetfulness, or behavioral change. No history suggestive of a cranial nerve involvement, such as a smell disturbance, visual disturbance, double vision, facial numbness, deviation of mouth, hearing difficulty, difficulty in chewing, swallowing, speech disturbance, regurgitation of food, difficulty in turning head from side to side, or a taste disturbance. No imbalance while trying to reach for an object, swaying sensation, or slurring of speech. No lightheadedness on standing up suddenly, no episodes of excess sweating or palpitation. There was no preceding fever or altered sensorium prior to onset of any of these symptoms in his childhood. No history of weight loss, joint pain, fever. No high risk sexual behavior. No history suggestive of a toxin exposure, such as intake of any native medication or other drug intake. No history of toxin exposure at his occupational place as well. Coming to past history, patient doesn't have any comorbidities such as diabetes, hypertension, or other chronic illness. No past surgical procedures or hospital admissions. He had a term delivery. His mother had a term delivery. He cried immediately after birth, and there was no history of requiring ICU care. No history of any developmental delay. He has had normal scholastic performance as a child. He is a non-smoker, non-alcohol consumer.
Okay. We'll start from the symptoms. So you told that long duration problem, 2.5 or more than 2.5 decades. So whatever is the neurological problem, it's a very chronic problem. And what is the problem? If you first thing is he developed a slippage of chapels, no?
Yes.
So if you analyze that symptom, what structure appears to have been involved first? Some asymmetry in the upper limb you told. In the lower limb, is it asymmetrical or symmetrical?
Symmetrical, both feet at the same time.
Okay, so it's a symmetrical onset slippage of chapel to start with. So according to you, initially patient, the chapel was slipping while climbing only and with awareness. So what do you think could be the structure that could have been involved?
Initially, it looks like a distal motor weakness. Later
Yes.
on, progressed.
Probably what muscles? While climbing, you told, and later it became level ground. No.
Yes.
So while climbing and walking on level ground, there can be minor differences in the muscles that are used distally as well as proximally. So in the distally, what will be the thing which will produce climbing up more difficult? What are situations where patients experience climbing up more difficult? So your patient experience climbing up more difficult. What about climbing down?
That developed later on, ma'am. After a few years, it developed.
So if climbing up is more difficult, forget about this patient. Let us imagine it's an MD student, MD exam. Somebody is asking, your patient initially experienced climbing up difficult. So what are the things which can manifest as climbing up difficulty? And what will be the manifestation if you want to tell? Climbing down is difficult in some situations. Climbing up is difficult in some situations. So both are difficult. It's the first symptom. Till then, this patient had been normal. No? So imagine we are seeing that patient at that age. So if somebody is telling climbing up is difficult, what are all the agonist muscles needed for climbing up? So agonist muscle needed for climbing up are spine extensors, hip extensors, knee extensors, and dorsiflexors of the ankle. So I am not bringing into this the chapel, but just imagining that climbing up is more difficult. So any one of these structures can be involved either at the LMN level or MN level. That is spine extensor, hip extensor, knee extensor, and dorsiflexors of the angle. So if the spine extensor is weak, what will happen? The patient will be bend at the spine. While climbing, we have to keep the spine in alignment with the side rails so that we climb without any imbalance. So you will find that there is a tendency for the person to bend the trunk while climbing up much more than what is needed and is not able to align in parallel to the side rails. Very less common conditions involve the paraspinal muscles first, like conditions with continuous muscle fiber activity syndrome. Some very rare diseases start with paraspinal, Deber-Semline, congenital hypothyroid disorders. These are very rare conditions involve the paraspinal muscles first, rigid spine syndromes, no? And continuous muscle fiber activity syndrome. So those are the conditions starts with spine. But commonest cause for climbing up difficulty is hip extensor. So if the hip extensor is weak, patient will not be able to lift one leg and put it on the step above. And when he tries to put it on the step above, instead of the Trendelenburg effect of opposite hip going up, that hip will fall down. So that is called hip dip phenomena. So patient will tell what happens, I am unable to lift my leg alternatively like the way everybody does. Instead, I have to little swing it across. And when I do that, when it reaches the step above, that hip down comes down. That is called hip dip sign. It's called hip dip sign. So that will mean, okay, the problem started in the hip extensors. If it is knee extensor, the patient will try to buckle on the knees. While he is trying to climb, he will try to buckle on the knees. That also happens in some specific selective muscle diseases where some muscles are selectively involved. Selectivity of muscle involvement is a typical feature of muscle disease. So it will be very useful which muscle got involved. It will give you a diagnosis, the heralding thing. Suppose it is the dorsiflexor that is weak. That time normally our gait, either you are climbing or you are walking on the level ground, it starts with a heel strike. Normally we initiate our ambulation with the heels striking the floor first and then the toes. First thing, we can imagine the way we walk only. Our heel will come into contact with the, in the gait cycle, our heel comes into contact with the floor first. This will be followed by the toes. So if there is a problem of the dorsiflexors of the angle, what will happen? Instead of the heel strike, patient will have a toe strike because he cannot elevate the dorsiflexors. He cannot elevate the feet. So the semiology of the gait cycle changes to a heel strike or to a toe strike. The toe first gait. Toe first means you are going to injure your toes and fall down. If you walk on your heel, that doesn't happen. So when there is a dorsiflexor of the angle weakness, people will have a tendency to change the semiology to toe first gait, because of which they tend to bend on the toes and fall down. So that is these are the various manifestations where climbing up becomes the initial symptomatology. In our patient, what happened was his chappals were slipping when he was climbing up. That means either this toe first dorsiflexors might have been affected, so that the climbing up part was affected, because he didn't bend his spine, he did not have hip dip, he did not fall on his knees, instead only his chappals were slipping. So two things would have happened. One is the toe grip become weak. If the toe grip is slightly weak, in the level ground, definitely you can adjust and walk. Because in the level ground, you can passively move forward, keeping the chappals in between your toes and need not grip much. Most of us do not use pressure to grip our toes, chappal, when you are walking on the level ground. But when the gait semiology changes to your toe first gait, he is not able to passively hold on to the chappal. So when it is toe first, the chappal will slip off when climbing up. So it's a very nice symptom that our patient had difficulty in gripping the chappals while climbing up. So it points to two muscles. One is probably mild weakness. So he did not sense it in the level ground. Mild weakness of dorsiflexors of the feet, as well as the intraossei. So his toe grip and dorsiflexion might have been weak. So when the toe first gait starts, he just passively permits the chappal to slip off. So with that history, probably my patient's disease started affecting the interossei as well as the dorsiflexors together. So it was predominantly motor at that point of time, very long duration disease. So if it is purely motor at that time, later you said that he forgot. So you are seeing him at 10 years. Supposing you go to a court as a give verdict, many patients are suing doctors now, why you did not diagnose at that time, then I would have changed my occupation, something and all, they will tell. You see, at that point, when it is purely motor, what are all the things you are going to consider? It's only two muscles are involved at that point. So the possibilities we will consider at that point, is it a length dependent motor dominant neuropathy? Is it a distal myopathy? These are the two things you will consider. Distal muscle disorders like distal myopathy with rimmed vacuole, DMR we call, no? So it may be a distal myopathy with a rimmed vacuole, or it may be a calpainopathy. He's only a 10-year-old boy. So calpainopathy start with the distal muscle involvement. Even though most of the muscle diseases start with the proximal girdle involvement, some muscle diseases start very distally and at this age group only, and it is purely motor at that point of time. So is it a distal myopathy with rimmed vacuole, or is it a calpainopathy, or is it a length dependent motor neuropathy? So these are the three possibilities we will consider with that first symptom if you have seen that boy at that point of time. So it is interossei and dorsiflexors of the angle that makes the first symptom. Next, you said that his chappal started slipping even while he is on the level ground. That means the weakness worsened. So even passively he could not, because two muscles are involved. It is both the dorsiflexors and the interossei. So same principle can be applied. Instead of the heel strike gait, toe first gait is coming, and the toe first gait is little more dominant now. So his chappal slips off passively while in the level. So it worsens. So it slowly progressed from the initial mild weakness to more weakness of the same muscles. Later you told that it slipped off without his knowledge. So slowly the sensory component is coming. So you have got a small sensory fibers as well as the large sensory fibers. So what is this that got involved? So now we know when it is sensory, out of the distal myopathy with rimmed vacuole, calpainopathies, that you can cut off. Because distal myopathies do not involve sensory fibers. So now sensation is coming into play. So what is the sensation that is involved? That is the thing. Supposing it is pain and temperature. So patient will normally to sense a chappal in your feet, you need proprioception. You don't need pain, you don't need temperature, because your chappal is neither pricking your feet nor it is altering your thermal sensitivity in the feet. So if the chappal is slipping without sensation, it is loss of proprioceptive sensation. So it is large fiber. Motor fibers or large fibers or small fibers? With reference to myelination, you classify the fibers into large fibers, small fibers, and very small fibers or unmyelinated fibers. So motor fibers and proprioceptive fibers come into large myelinated fibers. So first thing, we are excluding the distal myopathies, which we considered as a differential diagnosis after we get into the second symptom. So second symptom makes us little more wiser. We cut off the differential diagnosis, some of them. And now what you got is a little more wiser you will become. So you thought it is length-dependent motor neuropathy, but this motor neuropathy is now involving sensation, and it is picking up the myelin-based fibers. So there is some selectivity of fiber involvement apparent at that point of time. So it's a most myelinated motor fibers and the proprioceptive fibers. What they share in common is myelin, whereas their function is different. One is motor, another one is sensory. But what is common is the myelin. So it could be a demyelinating type of neuropathy. What type of demyelination will come to later. So because this disease is a nerve disease, second, it is a length-dependent nerve disease because it involves the longest nerves, and three, it is picking up the myelinated fibers. At this point of time, our diagnosis will be length-dependent, mixed sensory motor, demyelinating. So this much diagnosis you can make when he is 10 years and 6 months. So can you tell for the sake of discussion some non-length dependent nerve diseases, non-length dependent? Less common, they are less common.
Porphyrias.
Very good.
Uh,
Very good. So
infection, vasculitis related neuropathies.
Yes. So it can be mono. What vasculitis specifically is non-length dependent? Any vasculitis can produce mononeuritis multiplex, and that way it can be non-length dependent. But specifically non-length dependent neuropathy, which is face and upper limbs, is ganglionopathies, Sjogren's syndromes. No? So good, you told porphyria, amyloid, Tangiers disease. Porphyria, amyloid, Tangiers disease, sometimes chronic organophosphorus exposure, and acquired conditions like Sjogren's disease and other ganglionopathies, non-Sjogren's related ganglionopathies. So these are the non-length dependent neuropathies. We start in amyloid, porphyria, Tangiers, then chronic organophosphorus compound poisoning, and acquired conditions like Sjogren's vasculitis and other ganglionopathies. So these conditions you exclude. Even though you are thinking neuropathy, these conditions are less likely because it is length dependent, sensory motor, demyelinating. Large myelinated fibers have been picked up. I am sure you know all these things. I'm just making the template clear for you. So how to approach a difficult case. Sometimes you may have a difficult case. You put it on the template, then the diagnosis will become easy. Follow in a blinded template. So that is what. So at this point, it is length dependent, sensory motor, demyelinating, probably because myelin base is involved. Then you told that his calves were thinning. So it is slowly ascending. So from the distal part, it is ascending. What are all the calf muscles? In the calf is thinning means you have got a gastrocnemius, you have got soleus, you have got plantaris. No? The main bulk is made by the gastrocnemius. And you have got soleus, which is deeper, and you have got plantaris. No? So how is it possible for us to differentiate between what is involved in this patient? Apart from it's only a bulk loss he experienced, did he experience any other problem other than the bulk loss? He had a toe first?
He had.
You told that he had a toe first semiology apparently. Did he have any contractures at the ankle? Did he feel that his heel cord was tight? Did he?
He is not giving that history.
Okay, he is unable to. So calf muscles are becoming thin means it can be gastrocnemius, it can be soleus, it can be plantaris, or all three of them together. When you examine, some points might help you. Is it selectively soleus because it is having one type of fibers, the fast stitch fibers, and Gastrocnemius having both type 1 and type 2 fibers. So that is it, respecting any fiber type, you can try to do if you are differentiating between soleus and gastrocnemius. That is possible only if the patient has got a contracture and the contracture is becoming less when you flex the knee. Why? Because gastrocnemius originates from the femur, whereas soleus is purely in the leg. So if there is a selective involvement of the gastrocnemius, the contracture will be released when you put the origin into relaxation. So you flex the knee, the origin of the muscle becomes relaxed and the contracture becomes less. So that is the clue at the bedside for a gastrocnemius. Supposing it is soleus, the contracture remains same, whether the knee is flexed or not. So it could be any of these. So this we will keep in our mind. Is there any selectivity for fast stitch, slow stitch, or combined fast and slow stitch muscles are involved? So that will help us to know the type of fiber that is getting involved in this patient when you examine. If there is a contraction and if he gives a complaint like that, we can ask him when he sits down, is the contracture become relaxed? Because naturally when you sit down, you are putting the knee into relaxation. So contracture is obvious only when I am walking, and when I am sitting, it is less obvious. If the patient is telling you, then you can know it is gastrocnemius. Otherwise, we'll keep all the calf muscles as probably involved until we examine the patient. So the disease is ascending in the motor level. Next, what happened? Then what happened? What was the 8 years later?
He had
in the school and over the
he had a tripping of toes.
The tripping became more, no? According to you. So actually, tripping is a word which is used when the tripping is due to tightness. If it is a flail foot where the dorsiflexor is weak, you will only say that he was injuring the toes while he's walking and there was a high stepping.
Yes.
Tripping is used when there is a spastic or upper motor neuron type of foot drop, or it's a tender Achilles contracture. So it remains tight like that. So tripping is the word used when there is a tight toe first gait. When there is a flail toe first gait, which happens in acute injury to the sciatic nerve or common peroneal nerve, there you don't use the term tripping, we call it as a high stepping. So tripping is either TA contracture or spasticity. So if that was evident from the history, you can use that. Otherwise, better to tell that there was a toe first gait resulting in injury to the toe. So we will keep the options open, whatever might be LMN or EMN. So and he has to support of the nearby walls to prevent falls. So was he falling because of the tripping or was he buckling? Because from the distal part, you said that it went off to the calf. So now we don't know whether the thigh muscles are also getting involved. So he may be buckling and falling, or falling patient approach is also very important for MD student level, because fall prevention is a very important thing for any neurological patients. So once they fall and they fracture a bone, that will be the end of their disease. You put a plaster or operate whatever it is and put them on the bed. Then when they get up, they find that most of the nervous tissue is gone. So falling patient approach, we apart from this one, forget about this patient, somebody is falling. So we have got a flow chart for that. So falling with loss of consciousness. This just because you are small girls and boys, just for your use and you told me that there is no lightheadedness while standing and all those things you told. But it is better to have the template. It will be useful later. So one is falls with loss of consciousness. Anybody falling quickly, falls with loss of consciousness may be seizures or syncope. Syncope you faintly mentioned, it was probably not there. But in a context like this, whether the autonomic fibers involved, orthostatic syncopes, they can get orthostatic hypotension and syncope can happen. Or syncope can be due to various other causes, Stokadam attacks. I know that the patients with Stokadams getting labeled as epileptics until you get the typical history. So falls with loss of consciousness maybe seizure or syncope. Seizures will be usually very evident from the semiology. It may be atonic seizures are little difficult. So to think it's just falling like bones, you have to ask for loss of consciousness. Then syncope may be orthostatic hypotension. It can be cardiogenic syncope, or it can be syncope due to any other causes. Many other, you have got chromaffin tissue tumors where there is a syncope coming suddenly because of the release of biogenic amines like jugular foramen tumor. It may be less obvious, such a small thing. It may not be producing the cranial nerve palsy at that point of time. Patient will tell that I am getting episodic palpitation, flushing and falling. You look everywhere, you don't find anything. So that is a false due to chromaffin tissue tumors, syncope. And syncope due to stroke Adam attacks. And syncope due to orthostatic hypotension. And early autonomic neuropathy, the syncope can be very misleading. Like you can mistake it as hot water epilepsy. A patient might tell, whenever I am taking hot water bath, in a case like this, we are carefully looking for autonomic involvement. So when you take a hot water bath, what happens? There is vasodilatation. Autonomic may be well compromised during routine situations. But when he takes a hot water bath, there is flushing, vasodilatation. So to compensate for that vasodilatation induced stagnation of blood in the periphery, little more activation of autonomic function is needed. So hot water bath not only produces hot water epilepsy in some patients, but patients with autonomic neuropathy, one of the early symptoms may be syncope with hot water bath. It is easily mistaken as epilepsy, whereas it may be an autonomic neuropathy, which gets decompensated because of flushing and blood pools in the periphery and baroreceptors are not strong enough. So this is false with loss of consciousness. Then you can have micturition syncope in the night. Many of these patients get anticonvulsants. They get alcoholic drink, quickly get up from their bed and go to pass urine and they syncope, they faint there. Somebody will diagnose epilepsy. So there may be defecation syncope, micturition syncope. So false is it with loss of consciousness. If it is without loss of consciousness, is it fall with vertigo, false without vertigo? With vertigo, you have got something called, they may be able to tell vertigo happened. If they are able to tell, it is very good. Otherwise, there is a phenomena called Tumarkin's crisis, autolytic crisis of Tumarkin, which happens due to... it happens when there is a sudden endolymphatic hydrops. Endolymph increases, it can happen in Meniere's disease in some phase. So they don't know how they fell. They suddenly fall, they are so sick, they are vomiting, and they may keep their eyes closed, but they are conscious. That is called Tumarkin's crisis. But patient may not speak also, intensely frightened with severe vertigo. So that is Tumarkin's crisis. So falls with vertigo. So they may not be able to tell you, but after some time you see them very well and getting up and going away. So whereas if it is due to brainstem stroke or something like that, they will be going into a whole lot of neurological features. Then falls without vertigo, that may be buckling and falling, swaying and falling, reeling and falling, tripping and falling, falling forward, backward, sideways. So all this will help us to know where is the problem. So falling backward, forward, reeling, all points to basal ganglia cerebellar disorders. PSP syndrome, progressive supranuclear palsy. So there they will have a multi-directional sudden falls and they get up immediately. That is due to involvement of pedunculopontine oscillator complex in the course of PSP syndromes. Many of these patients, nothing is found at that time. So somebody will replace knee joints. I have seen people who come with replaced knee joints because somebody will think it's a cruciate ligament dysfunction. At that age, many people will have osteoarthritis of the knees. So somebody, because they early phase, nothing may be there. So falls, very important to differentiate. Painful falls, swollen knees, and disorganized joints, cruciate ligament dysfunction. There we call buckling and falling with pain. So you have to ask for buckling and falling. You are not asking for buckling and falling. Patient is falling and coming repeatedly. He is conscious. It may be early PSP. I have seen many PSP patients coming with knees replaced. The biggest tragedy is the knee replaced joints will get damaged because again they are going to fall again and again. So we are adding to their agony when you are unable to systematically analyze the fault. We presume something is there as the culprit and give them a treatment which puts them into more problem. So that is PSP faults, sudden multi-directional faults with immediate writing. Nothing may be there at that point of time. Your disease starts from the pedunculopontine oscillator complex. Then maybe the falling forward, backward idiopathic PD, sideward cerebellar faults. Buckling is painful buckling or painless buckling. Painful buckling is cruciate ligament dysfunction. Chronic osteoarthritis, where the cruciate ligaments are damaged. Then you can get it in tabes dorsalis. Even though the joint is destroyed, they may have painless fault. But it will be very obvious. The bones are destroyed due to sensory denervation. And so they may fall in joint disease without pain also. Commonly joint disease, they fall with pain. But they can fall with pain in neuropathic joints, which is typically seen in pseudotabes of diabetes and tabes dorsalis. Then painless buckling may be stiff buckling or flail buckling. Stiff buckling happens in pyramidal disease. In pyramidal disease, what happens? The music of movement is lost. Normally, there should be agonist activation, antagonist inhibition, synergist helping. So when there is a pyramidal disease, there is co-contraction of agonist and co-relaxation of co-relaxation. Because of that, they feel stiff, they fall down, and then they get up. Because instead of the forward moving muscles getting activated and the other muscles holding back, both will contract. So patient becomes stiff, buckles and fall. That's a stiff buckling is pyramidal buckling. Then if it's a flail buckling, it can be lumbosacral plexus, L3 radiculopathy, femoral neuropathy, quadriceps muscle. Then you have got at the angle, unstable angle joints. Generally, they invert or evert while they are walking fast, depending on inverter or everters are involved, which is also very common. Quickly moving the full foot invert. Then you can invert means you know that the lateral compartment has gone weak. Eversion and falling is very uncommon, but inverting and falling is common when the lateral compartment gets involved. But in your patient, he is already in the toe first, so maybe he is falling due to toe getting injured, and he may be spraining the ankle. So this is just a template for the falling patient. So in your patient, it is toe first. So probably he is when he is little careless and he is not lifting his foot sufficiently high, he may be landing on the toes and falling due to tripping over his toes. It is possible. I think that must be the cause. And you said that later he developed some sound. What is that sound? It is called stamping gait. So first is a high stepping gait with a toe first, and then you are getting a stamp. Stamp means the proprioception is also contributing. That is typically called as stick and the stamp gait. When the proprioception is gone, patients usually carry a stick to know how much is the floor away from the feet. But once they hit the floor with their stick and understand that this much is the height, they get confident and they remove their stick. But immediately again proprioception is not there. So elevate too high and bring it down without knowing where is the floor with a thud. That is called stick and the stamp gait. So the stamping component is sensory. The toe first component is motor and stamping component is sensory. So it's a mixed gait involving both motor and sensory from the history. And Some question was here, but I could not read that. Partially only was there. Somebody has asked some question, how to differentiate. Some question was there, but I could not read the full question. If you are able to read it, just tell me, I can
How
answer.
to differentiate UMN and element from history of case? Some people say we can differentiate using history by asking buckling. If present, it's element, otherwise it's human. Can you please elaborate on this?
Buckling in between Yemen and Element. You see, buckling in Yemen disease is not at all uncommon. Many paraplegic patients buckle and fall. That's a stiff buckling. Because, as I told, the kinetic melody, the melody of movement is maintained by the pyramidal tract. So when that is impaired or lost, what happens is, instead of agonist getting activated, normally what happens, the moving forward leg will be flexed. The leg which is remaining behind is extended. That is called stepping phenomenon. You don't hop or you don't jump or you don't drag normally because of the pyramidal tract. Pyramidal tract is helping us to have the stepping phenomenon. When one leg flexes, the other leg will extend. And this happens in an alternate fashion. This is mediated by the corticospinal tract through various locomotor centers. You have got locomotor center in the midbrain. You have got a thoracolumbar locomotor center through which the stepping phenomena is activated. So in a pyramidal tract disease, that stepping is not there because the locomotor center becomes weak, and so both legs will extend together and both legs will flex together. Because of that only most pyramidal patients drag. They are not able to flex one leg. So they drag both legs. Same will suddenly both co-contraction and co-relaxation. That is how they move forward, co-contraction and co-relaxation. That way they drag. We all tell a patient with pyramidal disease is dragging his leg. So we don't use high stepping or stamping, but they drag. They drag because of the stepping part. First step of the gait cycle is anti-gravity stretch. In our patient, anti-gravity stretch is affected, is high stepping. So anti-gravity stretch means you clear the foot from the floor, opposing the pull of the gravity. That can be affected in many diseases, and in our patient, it is affected in a high stepping. Second is stepping. Stepping is when one leg flexes, the other should extend. In pyramidal disease, this phenomena is gone. So you drag. And there is co-contraction and co-relaxation. When there is a co-contraction, you stand like a pillar. When there is a co-relaxation, you fall. That is how you fall in pyramidal disease. Whereas in LMN, it's a flail fall. Your quadriceps is weak, so the stepping is not really affected. You flaily fall on your knee. That's an LMN buckling. It will be very easy to differentiate when you see a hereditary spastic paraplegia, some patients like that, you can go back and see in your wards. Then you will see how they walk, and they will be buckling in a stiff way, like a log of wood. Whereas LMN patient will fall fly like a bag of bone. They'll just fall fly on their knees. They don't drag. They don't drag, and they may have other LMN features like what our patient is having. Clear, huh? Am I clear?
Yes, ma'am.
Yes. Okay. Next. So he was falling. Probably this patient had a sensory motor gait abnormality resulting in Tophus gait, which makes him stumble and fall. Okay, next. 1 to 2 falls per month. Okay.
Over the last 8 years, climbing up also has become difficult, and getting up from squatting.
We analyze. So climbing up, you can ask whether if he's able to tell. Everybody may not be able to. Normally, our Trendelenburg effect, when you put a leg above, that hip will go up. Instead, if it is a proximal, slowly from the calf, it is going up. Probably the hip extensors are also getting involved, maybe. Because at this point, he is not telling he is falling on this knee. So quadriceps we cannot implicate. Probably the hip extensors are getting involved, so he is unable to climb up. Climbing down is more difficult in conditions like lumbar canal stenosis. So neurogenic claudication. So when you bend your knees and climb down, the spinal cord becomes stretched. So the neurogenic claudication becomes unmasked when you are climbing down. Whereas in pyramidal disease, both climbing up and climbing down will be equally impaired because motor melody is needed for climbing up as well as for climbing down. So both are affected usually human disease. Climbing up is more affected usually spine extensor, hip extensor, dorsiflexors of the knee angle and knee extensor. Climbing down more difficult means you have to think of neurogenic claudication. So probably these patients' hip extensors are also getting involved now. So structure by structures, at the end of the history, we can tell the structures involved. So now it is probably, which is the hip extensor, gluteus medius. Whereas hip abductor is, gluteus maximus is the hip extensor, gluteus medius and minimus are abductor. So if the patient says that I am unable to climb straight, but I can abduct my hip and put it on the step above, that means it is gluteus maximus alone is involved. If both are involved, he will not be even able to swing his leg across and put it on the step above. That also will need help. So whether maximus alone is involved or medius and minimus is for abduction, whereas maximus is for extension. So if the person is precisely able to tell, we can precisely localize. Otherwise, we will just keep it like that. For the last 4 years, he also had difficulty in climbing downstairs. So climbing downstairs, you know, as I told, neurogenic claudication. Otherwise, if your knee muscles are involved, and climbing down becomes more difficult. Quadriceps is involved. Quadriceps and iliopsoas has to be stable when you are climbing down. So probably it started from the distal dorsiflexor, intraossei, went on to involve the calf muscles, then the hip extensors, and now probably the quadriceps and iliopsoas are also involved. So slowly, one by one, all muscles are getting involved. Then one getting up from the sitting postures, floor initially, and then on the knees. And then he has to climb up. Normally, how do we get up from the floor? When we sit in the floor, normally how we get up is we bring our legs under our thighs. When you are supposing, imagine you told this patient is from Tanjore, temple is there. Most of the ladies will be making flowers. So they sit with their legs stretched for long time on the floor. And after that, when the mala is ready, they will bring their legs under their thighs and then put both hands on the sides and get up N block, where the pelvis will be down, trunk will be vertically above. So first flex the thigh, flex the legs, bring it under the thigh, plant your hands on both sides, and the trunk and the upper part of the thigh moves N block. So that is how normally people climb up. So in patients like this, whichever muscle is causing the difficulty in getting up from the sitting posture, supposing it is a gluteus maximus, with this patient's gluteus maximus, hip extensor is very much involved in getting up from the sitting posture. So if it is gluteus maximus, which is the culprit, which has become very much affected, so patient is unable to get up from the squatting posture, and erector spinae is little more better, let us imagine. Because so far we did not get any history with reference to paraspinal muscles. Spine extensor, we did not get any history. It's not becoming bent or anything so far from the history. So imagine paraspinal is normal, hip extensor is weak. So we know that the erector spinae muscle has an attachment from the iliac crest. It has an origin from the iliac crest. So when the gluteus maximus has become weak due to whatever cause, the erector spinae's power will be borrowed to get up from the sitting posture. So what happens to that semiology? Erector spinae, supposing you are presenting this case, now you cannot be taking the casualty calls like that. When the erector spinae is coming to help the gluteus, it cannot keep the spine erect. As I told, normally when you get up from the floor, your spine will be erect, your pelvis will be down. So pelvis down and spine erect. Like that, you get up N block. Now the glutea is weak, so patient cannot get up from the floor. So he is asking the help of the erector spinae. So erector spinae cannot erect the spine. It has now changed its duty to lift the hip. So what will happen? Patient will become bent. You cannot imitate. A normal person cannot imitate this phenomenon. Very difficult. Many of the postures we can imitate and teach students. This we cannot imitate. So what happens when the patient gets up from the floor? Unlike the usual way where the pelvis is down and the spine is erect, here the spine will be bent because erector spinae switches off his role as a spine erector and uses his iliac crest attachment to pull up the patient. So as it switches off the spine erector function, patient will become bent. So instead of the pelvis remaining down, it goes up. So that is called hip up sign. Like hip dip in climbing, this is hip up. So patient will be bent like that. So that is the hip up sign. You can ask all those things, or you may see also. So hip up, hip goes up. Instead of the pelvis remaining down normally, the hip will go up, patient will be bent. Then he will try to lock his knees. If the ligaments are all right, he will try to lock his knees. So he will keep one hand on the knee, locking the knee. There are trick methods of getting up. And puts one hand on the floor. That means you are standing on two legs and one hand. That is the next thing. That is called tripod sign. So you are standing like a tripod. Then when you are sure that you are stable in that way, slowly lift that one hand and put it on the opposite knee. Then slowly release the erector spinae from the hip extension function to spine extension function. That happens by climbing. That is the classical Gower sign. So your hip goes up, spine becomes bent, then you become a tripod, and from the tripod, you slowly put your hands on the opposite knee and slowly climb on your legs. So that's a classical Gower sign that indicates hip extensor is weak and spine extensor is relatively better. So if the hip extensor is weak and spine extensor is better, only you'll get the Gower sign. So apparently it may be a Gower's because so far we did not get that symptom. So in the bedside, you can go and see the patient, how he gets up from the floor. You might find all the features that his hip is going up, trunk is bent, then the tripod, and then slowly he may climb. So that's what I think, but he will not be able to tell it. We may be able to demonstrate. Our patients may not know. While getting from the squatting, he takes the support of the floor initially. That all of us do that. That is normal. And then on the knees. So apparently like a Gower's, I think. Hip up and all those things, they will not be able to describe. We have to examine and see. Okay. So I think it's a hip extensor weakness. Now he requires one person to assist him by pushing forward while boarding the bus. So probably that hip extensors and abductors are also involved. So he is not able to rotate his leg and put it on the steps in the bus. So he has to be mechanically lifted and put. That's what I understand from this history. So probably the hip extensors were first involved, later the abductors. The abductors are spared. You can have a hip dip and abduct and push your leg on the step above. So if that is not becoming easy now at this point, somebody has to push him into the steps. That means hip extensors and hip abductors are also getting slowly involved. Next. So this is an exercise on the movement and the muscles. So next what happened? So now from distal to proximal, everything is involved. And by what about now at this point, the upper limbs are getting involved, I think, no? Is that your next complaint?
Yes, ma'am.
So
2 years after the lower limb weakness started, his upper limb weakness also began.
He noticed
Sorry,
swaying
2
while
years.
walking.
He had sensory symptoms.
Yes, that is there even before, from the chapel slipping, the stamping gait, and now he is getting the Romberg sign, wash basin sign. You are telling the wash basin sign is happening. So proprioception is also becoming progressively getting worse and worse, and swaying increase during the dark. So even otherwise they can sway because of the gluteus medius involvement. So the waddling is like a swaying only. It is different from the cerebellar swaying. Cerebellar swaying, the whole body will sway. It's the whole body sways side to side is cerebellar. Whereas gluteus medius weakness, they have the duck walking. So that will also look like a swaying, and that worsens during dark because of proprioception. And he is unable to feel the floor while walking. So the touch is also getting involved, but he can appreciate pain. So it is again more and more involvement of the large myelinating fibers. No tingling or burning sensation. That means what? You have got only negative features. So far, patient is not having any positive features. In motor, sensory, autonomic, everything there is an irritative symptom and a destructive symptom. So irritative symptoms start as, sensation start as paresthesia. You told tingling paresthesia, no? Paresthesias, dysesthesias, hyperalgesias. So these things are not there in your patient. It is all negative. It's only loss of proprioception, loss of touch, but there is no paresthesia. So how do you get paresthesia? In your MD exam, people will usually ask definition of paresthesia. So paresthesia is sensory perception in the absence of sensory stimuli. So you get a sensation of tingling even when you are not touching the patient. So paresthesia is sensory perception in the absence of sensory stimuli. Why that is happening? Through, you know that there is a bombardment of human system by so many sensations: visual, auditory, tactile, air blowing, temperature, insects, dust particle. No? So the nervous system filters. A good nervous system is a very good filter. It is not a facilitator. It does not facilitate everything in the environment to go into your system. If it goes, you cannot focus on anything. So it filters off unwanted things and permits only the wanted thing to go. For that, for sensation also, there is a modulation from periphery to center. So modulation, small fibers are always inhibited by the large fiber. So large proprioceptive fibers from periphery to center, that is called, you might have heard about the gate control theory of Melsack and Wald. Have you read it? Gating mechanism. So in the spinal cord, it is the Melsack and Wald mechanism. But in the periphery, large myelinated fiber is inhibiting the small myelinated fiber. That is why intractable pain is treated with the posterior column stimulation. Dorsal column stimulation is a treatment method for intractable pain. Somebody is having a destructive cancer in one leg, some sarcoma. He is beyond the treatment level. So palliation, you want to give pain relief. Dorsal column stimulation is used because dorsal column inhibits pain and temperature. And proprioceptive fibers inhibit pain and temperature fibers. So when this is disinhibited, modulation in the periphery is disinhibited, you get the paresthesia. So all unwanted sensations are permitted to pass and you get paresthesia. So disinhibition of normal modulation of proprioceptive fibers and the small fibers due to disproportionate progressive loss of proprioceptive function or irritative function of the small fiber. So sensory perception in the absence of sensory stimuli due to irritative disease of small fiber or progressive destructive disease of large fiber. So this will happen when there is a continuous modulation failure. That is paresthesia. What is dysesthesia is altered perception of a sensory stimuli. You are only touching, but the patient is howling. You pricked me with a needle or something like that, patient is telling. altered perception of sensory stimuli, dysesthesia. Why dysesthesia happens? The mechanism is called neuronal crosstalk. That is when one fiber is destroyed, another type of sensory fiber is trying to repair that, which is not affected. So supposing you are going to a cardiology class, a falling patient. Cardiologist will be going on talking about stroke atom attacks, whereas a neurologist will be going on talking about seizures. So depending on your specialty. So in the periphery, you have got a destruction of a proprioceptive fiber. A pain and temperature fiber is trying to repair that. So what will happen? Distally, it is the proprioception that is carried, but proximally it is carried through the pain and temperature fiber, which only knows pain and temperature. So it will carry that sensation until severe pain. So that is dysesthesia. Dysesthesia indicates repair mechanism is happening. Even though it is like a malunited fracture. It's an ineffective repair. But dysesthesia indicates repair mechanisms. Whereas hyperalgesia is lowered threshold for sensory perception. Supposing you have an abscess. You just touch, there is so much pain. So that is hyperalgesia. It may be chemical, neural, or psychic. Chemical means you have got slow reacting substance of anaphylaxis, substance P, and all inflammatory mediators. They protect the organism by lowering the threshold for pain appreciation so that you don't hurt them. Or previously patients, so psychic also is there. Supposing previously somebody has touched you in the morning around an abscess and there was so much pain. And somebody is coming near the abscess, then itself patient starts howling because it is psychic. So it may be chemical, neural, or psychic. Neural is what I told, large fiber is going on inhibiting the small fiber from periphery to center. In the spinal cord, it is gating at the Rexed laminations. And then these fibers go and organize in the thalamo-mesencephalic junction. And from there, they divide into a sensory component, a motor component, and a limbic component. Sensory component goes to sensory cortex. And motor component goes to subthalamic nucleus in the motor cortex. Why? Supposing somebody is giving you pain, you have to run away from that. So sensory and motor are always linked. So sensory fibers get organized in thalamo-mesencephalic junction and divide into 3 bundles. One is the pure sensory, which goes to sensory cortex for sensory appreciation. Second is the motor component for motor reaction by the patient, withdrawing the limb. And the psychic component, who hurt me? So is it cancer, is it injury, or is it my loved one? So that is the psychic component. So psychic component is the one which will be producing more suffering. Why I got this cancer? No? So that is the most painful phenomenon. Why I got this cancer? Is it my past karma? What happened? So that is the psychic component. So it splits like that and goes and settles. So that is the way the pain mechanism. So all these indicate there is a modulatory failure. Whereas in conditions where there is no modulation or more disproportionate destruction going on, no repair taking place, there is no positive features. So absence of positive features indicate there is no repair, there is no disproportionate modulation. Whatever was there at the time of your birth is getting destroyed in a selective way. There is no modulatory failure. So your patient is not having any positive sensory features that indicate there is no repair, so there is no dysesthesia. There is no modulatory failure, there is only uniform loss. There is no modulatory failure of proprioceptive fiber on the small fiber. There is only uniform loss. So you are not having paresthesia. So absence of positive symptoms indicate there is no progressive modulatory failure and there is no repair taking place. When there is repair, you get dysesthesia. So both are not there. So that's a very important feature in your patient. So your patient is having sensory motor, very long duration, length dependent, myelinated fibers are involved. but there are no positive sensory features. That indicates there is no progressive modulatory failure or there is no repair taking place. So so next point you are getting when you said that there is no tingling, there is no burning, you are conveying to everyone that this patient does not have any progressive modulatory failure or no repair is taking place. And motor positive features, we tell cramps, fasciculations, contractures, myokymia. So all these are seen in acute denervation and anterior console disease. So there is no acute denervation, there is no anterior console disease. So there is no positive motor features. Positive motor features are fasciculations, fibrillations, cramps, contractures, myokymia. None of them are there. Myokymias and they happen in acute denervation, whereas fasciculations, anterior console disease, cramps and contractures occur in metabolic disorders, where there is a disproportionate supply of nutrients. So when the energy deprived state of the muscle, mitochondrial disease or storage disorders, where muscle is not having the enough ATP. So cramps indicate energy deprivation. So none of these positive motor is not there. So there is no anterior console, there is no acute denervation, there is only chronic denervation, and there is no neurometabolic diseases which is reducing the ATP. So patient is not having any positive motor. He is not having any positive sensory because there is no progressive modulatory failure and there is no repair. So very important two clues we have got at this point of time when you presented that he has no tingling, he has no other motor features. Okay, next. So this much only. Upper limb, you said that upper limb initially he developed progressive upper limb, difficult in lifting. Earlier he was able to lift. Now he loses the grip and so he has upper limb. Did it start proximally? Initially lifting heavy weight is a proximal function.
But slippage, grip is the issue one.
So distal only.
Distal only, buttoning and unbuttoning he had lived. Later on only, now also he's still able to lift his hand to comb his hair and bring food to his mouth. He's still able to do that. So buttoning and unbuttoning is a precision grip. Unbuttoning and buttoning is opponents. Mixing food is lumbricals. And food grains you said is unable to hold in between the fingers. That is indrashi. So but opponents, indrashi, and lumbricals. Lumbricals for mixing, opponents for buttoning, unbuttoning, and food slipping in between is indrashi. So all the small muscles are involved more, and then mild proximal. Lifting is still possible, no? So yes, more distal motor in the involved. You develop grabbing the railing and climbing. Similar complaints the right. So mild asymmetry in the upper limb. Left became earlier involved than the right. Did he have any, is he a right-handed person or left-handed person? He is a right-handed person. So sometimes if he is a left-handed person, they feel it on the dominant hand early. So it is not so, it's a true asymmetry, but that asymmetry is, that also we will note down. So mild asymmetry in the upper limb. We'll keep it in our mind. Okay. Then you, so that asymmetry, we have to keep it in our mind to look for the differential diagnosis. When you use differential diagnosis, you have to keep that point. So far, it is a no negative, no positive, length dependent, motor sensory, myelin preferring, Ellerman syndrome. One odd feature is the asymmetry. So I'll keep it like that. Okay. Then also deformity. Did he develop clawing? Yes, ma'am. He developed clawing. So was it a complete clawing or a partial clawing? Complete. All fingers were involved. So the point will be if it is a mononeuritis, you get partial clawing. If it is ulnar nerve, so you might get only a partial clawing. If it is a median nerve, you will get only a
medial lateral clawing. But if it is a uniform clawing, complete clawing involving all the fingers, that indicates again a length dependent neuropathy involving the upper limb rather than a mononeuritis. Because there is an asymmetry in the upper limb, or you getting a mononeuritis. We have to keep it in our mind. If it is a mononeuritis, asymmetry is well explained. If it is not, then so that we will keep it in our mind. It is not, it's a uniform clawing. Okay. All the toes, all the fingers, then deformity of both hands. But he was unable to bring the foot to the mouth. He was able to bring. Okay.
He's able to.
Next. You said that his cranial nerves were not involved, no?
Not involved.
Not the cranial nerves. So in a patient like this, use of cranial nerves will be a very important clue. If you have loss of smell in a length-dependent neuropathy, mild asymmetry is there, that apart. In a length-dependent neuropathy, loss of smell is seen in Ruxham's disease. Then supposing you get optic nerve, nutritional neuropathies, toxic neuropathies, mitochondrial neuropathies. Then oculomotor, you get in acute conditions, not chronic conditions. Oculomotor, you get in Miller-Fisher syndrome, and toxic like tick bite inducing a neuroparalytic disorders. Then you get in oculomotor, not classically, you don't get it in chronic neuropathies. Fifth nerve involvement, you may find it in Sjogren's disease, and in chronic neuropathy, you get it in Dejerine-Sota. Among chronic neuropathy, fifth nerve gets involved in Dejerine-Sota. Then another drug poisoning, stilbamidine. There is a condition called Kala-Azar, which is now almost extinct. Antimony compounds used to be used in the treatment of Kala-Azar. So chronic antimony poisonings, stilbamidine. So Sjogren's disease, stilbamidine and Dejerine-Sota can involve the fifth nerve. Then eighth nerve involvement is very typically seen in mitochondrial disease, vasculitis, and toxins. So eighth nerve involvement, mitochondrial disease, vasculitis, and toxins. Then lower cranial nerve involvement in something which resembles a neuropathy, you can find in craniovertebral junction anomalies, or the tongue involvement you find in amyloidosis, amyloid neuropathies. So these are some of the points. And acute denervation, facial nerve involvement, lower cranial, palatal involvement can happen in AADPs, CADP, CADP-like conditions, lower cranial gets involved, amyloid pieces, tongue involvement. So these are the various role of cranial nerves. And RP, you can find it in mitochondrial NARP. NARP is a mitochondrial disease where you get RP, retinitis pigmentosa with deafness and neuropathy. So these are the, none of the cranial nerves are involved in our patients, so it's not helping us. And no balance will, no imbalance, we'll try to reach for an object, so lightheadedness, okay. Autonomic system is not involved. Next. So that's all, huh? That's all. You told that he developed some ulcers. No?
Yes,
so what is the term you use for this kind? So far, it's a length-dependent, sensory motor, demyelinating, LMN syndrome with no positive motor or sensory features, no ANS involvement, only odd feature, mild asymmetry in the upper limb. Now he is developing ulcers. So this, when you get ulcers, what is the term used? Acrodystrophic syndrome. So this is a, if you want to tell a complete diagnosis, length dependent, sensory motor, large myelinated fiber involved element syndrome with no positive features at all, and acrodystrophic. So it's an acrodystrophic neuropathy involving the large myelinated fibers, length-dependent fashion. One asymmetry is there that we will keep in our back of the mind when we examine, when we investigate the case. When there is an asymmetry, that is important for us to keep. So it's a very long duration. So any peripheral nerve disease, you can classify it into very long duration, very short duration, and relapsing remitting. So you can very long duration of several years is usually seen in inherited neuropathies, which you have already felt as the possibility, but the points are very long duration. 2, symptoms will be less than the signs. Patient may be not knowing what is normal at all. So he may not complain much. Even before 10 years, he might have had mild symptoms, but symptoms are less. And when you are examining, you find so much signs. How did he live up to this year? How did he get a job, and how did he move about? You will be wondering, looking at the patient. But relatively less complaints. Usually it's the reverse. So many complaints, pain here, pain there, this, that, people will tell. And when you examine, you might not find much. Whereas in long duration neuropathy of inherited nature, symptoms are generally less, but signs are very much more. Third important point is absence of positive features. Because there is no repair, there is no regeneration, there is no progressive modulatory failure in inherited neuropathies. So there is no positive symptoms. Fourth is family history. If it is there, it is supportive. If it is not there, also it can be there. So taking all this, some family history is there, I think. No?
Yes, ma'am. Maternal grandfather was supposed to have a high stepping gait alone. That is the but patient and neither patient nor the other informant, his elder sister, are exactly aware of what was wrong with their grandfather. They were told that he used to walk like this patient.
And he is the product of consanguineous parent.
Yes, third degree consanguineous.
So we have explained most of the features, but we have not explained the asymmetry. No?
Yes.
Why is he having asymmetry in the history? So can inherited neuropathies be asymmetrical? One is HNPPs, hereditary neuropathy for tendency for pressure palsy. But this is not fitting into that case.
There's no recovery. This is completely progressive.
So inherited neuropathies which can be asymmetrical, or one is HNPP. Second is double crush syndrome, Sweetal. Supposing your peripheral nerves are already destroyed by one disease, superimposition of another disease. Like it is more easy. If you stand on your elbows or you try to rest on your elbows, then the previously compromised nerve is more vulnerable for injury of any nature. It can be an entrapment across the cubital tunnel, or it may be a vasculitic process or an infective process. Anything is more probable, more easy to manifest in a patient who is already having a compromised nerves. So it may be a double crush. Why is he asymmetric? Third thing, an imitator of a distal symmetrical neuropathy is a cervical and lumbar canal stenosis. Lumbar canal stenosis can conglomerate roots. Coalescing roots will look like a nerve. So multiple roots which are coalesced. So this is a dominantly inherited condition like a craniostenosis. So patients develop this Creutzfeldt's disease. And like that, cervical and lumbar canal stenosis can run in families. So that can, in the cervical canal, it may be an asymmetrical radiculopathy. So these are the thought process when this patient is having radiculopathy. Asymmetry. Does he have an inherited neuropathy with a tendency to be asymmetrical? Straight away, no, because that's the way it is presenting. They present it foot drop, wrist drop, asymmetrical, and that is how it goes on from the beginning. But it was not like that. Second point is the person with an inherited neuropathy is having an acquired complication, which is more prone. Or is my patient having an imitator? like a cervical and lumbar canal stenosis, where the coalescing roots are resembling a nerve. Coalescing roots can resemble a nerve. So is that my patient? Because the treatment option is there. And another important thing you should never forget is the inherited metabolic disorders, like Imerslund-Gaisbach syndrome, it is called fetal transporter defect. They resemble an inherited neuropathy. Family history will be there, but you might find abnormal RBCs. You might find white cell count altered, anemia, megaloblastic anemia, which also runs in family, then easily can treat. That is called Imerslund-Gaisbach syndrome, where there is a transporter defect, transcobalamin 1 and 2 deficiency. So you are not transporting. So it runs in families. So even though it is a familial, it may be a treatable disease. So am I dealing with any of these conditions? Some atypical feature is there, because we may easily miss them. And if it is cervical lumbar canal, surgical option is there. If it is a Imerslund-Gaisbach syndrome, you have got an easy treatment. So you will have to be keeping your mind open, picking up the hard signs. We always said that soft signs, hard signs, and odd signs. Any case, soft signs will be ache there, pain there, tiredness, fatigue, everybody has. So you will never make a diagnosis on a soft sign. Hard signs are very long duration. Myelinated fibers are involved, and length-dependent fashion is there. So, and no positive features at all. They are very hard signs. There is no differential diagnosis at that point of time. So you make a diagnosis on hard sign. But what is odd? Why is my patient having asymmetry? And why is my patient having acrodystrophic change? Because acrodystrophic changes are more common with small fiber involvement. So towards the end of the disease, after involving over 3 decades, the large myelinated fiber, my patient is slowly getting into the small myelinated fiber also. That will happen, completion of disease, completion of pathology, all fibers are getting involved. So acrodystrophic feature is an odd feature for whatever we are discussing so far, but it is end of the disease. If acrodystrophic is yearly, then you will think of Hansen's disease, hereditary sensory neuropathies, sensory autonomic neuropathies. They are all typically classified as acrodystrophic neuropathies, where the small fiber gets involved very early. The Marfan's disease, Denny-Brown's, hereditary sensory autonomic neuropathies, human pincushions, hereditary insensitivity pain. All these conditions, acrodystrophic change comes very early. Whereas in your patient, the acrodystrophic change came very late. So that way you can explain. Completion of pathology, my patient is now getting involvement of the last surviving small sensory fibers. So that has produced the acrodystrophic change. The asymmetry still remains to be confirmed, for which we keep our mind open and we'll examine the patient. Yes. Examine.
Patient is thin-built, normally nourished young male, conscious, oriented to time, place, and person. Pulse rate of 82 per minute, regular, normal volume and character, normal vessel wall condition, or all peripheral pulses are felt. There's no radiofemoral delay. Blood pressure in right supine position was 130 by 80 in right upper arm, and in sitting position it was 126 by 80. There was no orthostatic hypotension. Also, rate was 14 per minute, temperature 98.3 degree Fahrenheit, saturation was normal, no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. He had multiple small ulcerations over both feet in the soles, as well as over the toes, various stages of healing. He had scanty hair over both lower limbs, no skin discoloration or shininess, no neurocutaneous markers, no markers of atherosclerosis. BCG scar is present. He has a normal BMI with a normal upper segment, lower segment ratio. Coming to nervous system examination, higher mental functions were normal. He was conscious, oriented, cooperative. Language was normal in terms of comprehension, fluency, naming, repetition, and writing. Speech was normal. Mini mental state examination score was 30. Lobar functions were normal. Cranial nerve examination was normal. First, olfactory, optic, extraocular movements were normal. Trigeminal was normal. 7th, 8th cranial nerve, 9th and 10th, 11th and 12th, all nerves were normal. Coming to motor system examination, patient was lying in supine position with his arms by the side, hip and knees in extension, and ankle in neutral position. He had deformity, bilateral high bulk was reduced in forearm as well as in hypothenuse muscles showing waist. In lower limbs, his calf muscles were thinned out with only 21 centimeter, but it was equal in both right and left upper limb as well as lower limb. Dorsum of the foot, the tendons were very prominent with EDB wasting. Tone was reduced in all 4 limbs. Power, there was a distal weakness which was more profound than proximal weakness, with shoulder power being 4 in all movements, elbow power being 3 in flexion and extension, wrist being 3 in flexion and extension, and all small muscles of hand showed weakness in both upper limbs. There was no asymmetry in examination.
No asymmetry.
Lower limb.
So did he have asymmetry during the course of evolution? Maybe, no?
In upper limb, he complained that left upper limb began earlier than right upper limb, but when he presented to us, it was equal.
Apparently, from the history, 2 years. Mild asymmetry, short period of asymmetry is well described, but 2 years of difference between both sides.
1 year, 1 year. Within 1 year, his left.
So that asymmetry.
Within 1 year, right upper limb also was involved.
Probably the asymmetry of 2 years may be a soft feature. We are not able to demonstrate that asymmetry. So you don't have to consider second, that is called double crush syndrome, 2 etiologies, like median entrapment or ulnar nerve entrapment or pressure symptoms or an infective pathology superadding on a degenerative pathology. So these are the things we'll have to consider when there is a persistent asymmetry in a case like this. But it is not there means maybe it may not be that 2 years, so his timing judgment may be not that much. Maybe for a short period there was asymmetry. That is the possibility you have to take note.
Coming to lower limb power, this was also showing a distal more than proximal weakness with patient having a hip 4-5, whereas at knee the power was 3/5 in all movements. And patient had 0/5 power in dorsiflexion and 1/5 power for plantar flexion. His toe flexion and extension were 0/5. Trunk muscle power was normal. Reflexes, all superficial reflexes were present and plantar was flexor bilaterally, whereas all deep tendon reflexes, including biceps, triceps, supinator, knee and ankle were absent. Coming to sensory system examination, patient had a graded sensory loss in all modalities, including pain and temperature, pain being impaired till elbow in upper limb, equally in both right and left upper limbs, and in lower limb it was impaired till hip joint. Temperature sensation was impaired till wrist and in upper limb and till knee in lower limbs. Fine touch, vibration, proprioception and joint position sense all were showing graded loss in both upper and lower limbs, equally in right and left upper limb, left limbs. Fine touch was impaired till shoulder, that too more profound in the fingertips compared to arm, and in lower limbs it was impaired till hip joint. Vibration was impaired till wrist in upper limb and till anterior superior iliac spine in lower limbs. Proprioception and joint position sense was impaired till wrist in upper limbs and till ankle in lower limbs.
That acrodystrophy happens when the small fiber is involved. It doesn't happen in the large fiber involved.
Patient had a positive Romberg.
Okay.
cerebellar examination, finger nose test was normal. Heel could not carry because weakness.
Cerebellum is
Dysdiadochokinesia
normal.
was absent. There was cerebellum is normal. There was no spinal deformity or meningeal signs. There was no paraspinal muscle hypertrophy. Peripheral nerves, there was no thickening. Other system examination was normal.
Okay. So at the end of your history and examination, at the end of our history, we wrote our diagnosis and kept the odd feature. But after examination, the odd feature is nulled. And we are now sure that the small fibers are also involved. Even though initially it was definitely not involved. It is end of the disease. So, and still the diagnosis remains a very long duration, steadily progressive. Long duration sometimes can be acquired also, like juvenile diabetes or chronic exposure to environmental toxins. So they can be long, or even chronic demyelinating neuropathies which are untreated, CIDP, untreated CIDPs. So that can be very long duration. But there will be other features of an acute neuropathy, like a positive features. Usually, I am sure you might have seen so many diabetics. Their main symptom is burning paresthesia. Even their cloth touching their feet is disturbing to them. So we give symptomatic medicines to reduce the paresthesia. So positive feature is a typical feature of acute neuropathies. None of those things are there. So it's a chronic neuropathy with typical features of an inherited neuropathy. That asymmetry is also now not there. So it's a straightforward condition. So you'll have to now categorize into what type you are going to do. You have got so many classifications, you know that. But as in the examination, you can use a clinical classification because you are not going to be provided with a histopathology or genetics report. So Deacon-Lambert classification is the bedside classification. So that will be ideal for a clinical examination. But of course, you have to follow whatever your teachers are telling you to follow. Genetic classification is not at all possible in your clinical exam. Genetics plus histopathology is the latest classification of inherited neuropathies. So this will qualify for a hereditary sensory motor neuropathy, probably demyelinating type end stage. Hereditary motor sensory neuropathies may be so many types in the Deacon-Lambert. One is type 1 is axonal, type 2 is demyelination, type 3 is Refsum, type 4 is Dejerin-Sota, type 5 is with spastic paraplegia, that is peripheral neuropathy with spasticity. And next is with RP with optic atrophy. So these are the classification of Deacon-Lambert. Under that, it is not a Refsum because patient is not having loss of smell. He is not having ichthyosis. He is not having deafness. So, and these features are very important to recognize. Why you should recognize Refsum's disease? Because it is treatable. There is accumulation of phytonic acid that can be dialyzed and removed. And there are dietary restrictions where phytonic acid restricted diet is available. So among the inherited neuropathy, Refsums you should recognize, but there will be ichthyosis, deafness, those things are there, so it's not there. So it's not Refsum. And Dejerin-Sota becomes symptomatic very early. This boy also became symptomatic early only, but the clues will be kyphoscoliosis. You said that till the late, this patient's paraspinal muscles were not involved. Whereas Dejerin-Sota has got a tendency to involve the paraspinal muscles. Because of that, they develop spinal deformity. And second point for Dejerin-Sota is trigeminal neuropathy. So facial sensory loss. And third point is you said the nerves are not enlarged. So it's an enlarged but not thick nerve. Dejerin-Sota, very early manifestation, trigeminal neuropathy, paraspinal muscle involvement, enlarged soft nerves. So it is called soft succulent nerves. When you try to move the ulnar nerve, you will find that the ulnar nerve is very big. But unlike Hansen's disease or neurofibromatosis, it is not thick. So they are described as soft succulent nerve. So none of the features including paraspinal muscles are spared. So it is not Dejerine-Sota. He is obviously not having spasticity, is not having optic atrophy, is not having RP. So this will become a Dicken-Lambert type 2. Apparently, this is Dicken-Lambert type 2 clinically. Genetic classification depends on your genetics, and now there is no recommendation for, because people use the histopathology also in the latest classification that is used for research purpose only. So myelin, folded myelin, what is the nature of the myelin? What is the nature of the axon? What is the fiber count? All these parameters are included, and genetic is also included. That is the genetic classification. That is a research classification. So that we need not tell, you just remember. So it is a Dicken-Lambert classification is sufficient. For this is a straightforward case, but I just carried through the symptoms and you gave a not so straightforward case, or you get a coagulation syndrome. Hereditary neuropathy patient is having leprosy, or to treat leprosy. You see, so that way it is important. Acrodystrophic change also, you have to think whether it's the end of the disease or is he having a superadded. Classical acrodystrophic disease neuropathy in our country used to be Hansen's disease. Now Hansen's has become eliminated in many parts of India, except some pockets in Tamil Nadu and some small Bihar, Madhya Pradesh. Some states only are still having some Hansen's, recently some cases from Kerala, but almost it has become very much less. But the classical acrodystrophic neuropathy is Hansen's disease, and that will be in a mononeuritis pattern. There will be patches, there will be thick nerves. Those are not there. So yeah, why you should pick up an odd feature? To find an additional cause which can complicate these patients. They are not immune for the other causes of neuropathies. That part you should pick up. So what are the things in which I can help my patient? If you just dump him as a hereditary neuropathy, you are not going to help him at all. So is there an additional nutritional component? Is there an infective component? Is there an entrapment? When he says, that is where the odd features are going to help. The typical features are fitting into probably type 2 HMSN, but something odd was there which was not seen after examination. So probably you don't have much to offer other than non-pharmacological approach. Sometimes we protect the feet, ulceration, trophic change, bony division, that will be end of his life. So you have to give him the protective devices to protect his feet. High dose vitamin C is used. And you also use brain-derived neurotrophic factors. That is not available. It is only for BDNF is used. Once progestational agents used to be used, they are having more complications than benefits. So progestational agents are abandoned. BDNF is in the research tool. It is still used, but not at all available for us. High dose vitamin C is supposed to slow down the progression. So 2 to 3 grams, only thing. The problem is they may have renal stones. So you hydrate them and they have to pass urine. Now this patient has reached the end stage. Now what you can do is external support system. You can give a AFO and you can give the MCR chapels. Tell him to look after his feet like the face so that he doesn't go into cellulitis and other complications silently. And gaiter is there which will give proximal support. So that kind of external appliances only, and you can still give some vitamin C in case it helps him slow down. BDNF option is not easily available for the patients, for all patients. It is only available in the research tool. So any questions are there, you can ask me. You know the case. I just told you how to approach a case, that's all. Any doubt is there? That approach will help you in a global situation, not in this case. So anything you have, any questions are there, I can answer. Good, Ma, you presented very well and you took a detailed history, that is very nice. So excellent. Only thing, I tell students that I am now retired for 2.5 years. You see, what people tell, as long as you see patients, you should be like an undergraduate student. Spend time, especially neurological patients. You have to take a thorough history. Once you graduate, you should not become quick. You should thoroughly see. And even in patients whom we diagnose, nothing much can be offer what can be. There will be something which you can offer that you should definitely tell them. Like preventing from ulceration, protecting feet from cellulitis, infection, looking after feet like face, all those information conveyed will be very useful for them. And prevent some of contractures and use of, you have got a proximal gaiter. The whole leg can be put into that and it can be attached to the trunk. The trunk muscles are not involved. So he can still walk little more better. So all those things you will have to advise this patient. So throughout life, remain committed to science. That's the most important thing I always tell. Even the patients are beating us, all those things, but 1-2 things I have already put one talk on art and science of medicine in your White Army only, because we are answerable for what we do. If they think we are gods and we can save all lives, it is their mistake. And patient and doctor is not two things. Today you are a doctor, tomorrow you'll be a patient. It is applicable for all of us. So we will be what we are. In that art and science lecture, we should not dilute our quality because society has become hostile. That is their aspect and this is our aspect. So, and you are studying in a very prestigious institute, so you should maintain the quality throughout in patient care delivery. That is the purpose of the training. So good, nice. Any questions I can answer?
Thank you very much for the wonderful session, ma'am. We have learned a lot.